If your top blood pressure number looks normal, that does not automatically mean you are safe. For people over 60, nearly 1 in 3 who go on to have a stroke had a systolic, the top number, their doctor considered perfectly controlled. Yet in visit after visit, almost nobody paid real attention to the number underneath it. The bottom number, your diastolic, often sits there like a quiet afterthought. It is not a footnote. After 60, it can be the loudest warning your body sends you, and almost nobody is listening. In most clinics, especially in a rushed 10-15-minute appointment, the conversation chases one target. Bring the top number down. Hit the guideline, tick the box, see you in 6 months. The chart looks good, the system feels satisfied. But while everyone celebrates that top number, the bottom number can quietly sink too low, or the gap between the two can stretch too wide. Either of those changes can significantly raise your risk of stroke, heart problems, and episodes of dizziness or confusion, and they are missed constantly. I have watched this play out in clinic far more times than I'm comfortable admitting. A patient sits in front of me with a long list of medications. Their systolic looks beautiful. They are proud. They truly believe they are done, that they have crossed some invisible finish line, but they have not yet. They are looking at half the story and assuming it is the whole book. Why is this so easy to miss? Because a normal top number feels like good news. It gets circled on the printout, praised out loud, and tracked over time. The way we talk about blood pressure teaches people, and many clinicians, to think of that top number as the star of the show. The bottom number gets read, maybe written down, and then mentally ignored. Historically, that made some sense for younger people. For those under about 50, diastolic matter less on its own. But past 60, the physics of your arteries change. The rules literally rewrite themselves inside your body, and most of our conversations never update to match. So before I tell you the one detail that truly flips how you think about safe numbers, you need the full picture of why this happens in the first place. Otherwise, when it shows up in your own readings or in a parent's, you will miss it. Imagine a young, healthy artery like a flexible rubber hose. When your heart pumps, that hose stretches to absorb the surge of pressure. Then it springs back, pushing blood forward between beats. That spring back is what keeps your diastolic pressure in a healthy range. It is also what quietly feeds blood into your own heart's arteries and into your brain during the resting phase between heartbeats. In other words, the bottom number is about how well your organs are being supplied when the heart is resting, not just when it is squeezing. Now picture that same hose after 30, 40, 50 years of wear. Sun, weather, time. It stiffens. It stops behaving like a stretchy rubber tube and starts behaving more like a rigid garden hose that has been left out in the sun for a decade. It barely flexes at all. It cannot stretch to soften the pulse, and it cannot spring back to maintain pressure between beats. Here's the twist almost nobody explains clearly. When the artery stiffens, the systolic, the top number, tends to climb, because that rigid pipe cannot absorb the pump's initial force. At the very same time, the diastolic, the bottom number, tends to fall, because there is almost no elastic recoil left to keep pressure up between beats. One mechanism, two opposite movements, rising top number, falling bottom number. And yet most blood pressure conversations track only the top. The difference between those two numbers has a name: pulse pressure. It is not just a bit of math on a page. That gap, especially when it is wide, is one of the strongest predictors we have for stroke risk in older adults. Stiff pipes, wide gap, higher risk. That is the basic mechanism in a single sentence. So here's your first practical move, and I'm going to ask you to actually do it, not just nod along. Grab your most recent blood pressure reading. Subtract the bottom number from the top number. If that gap is 60 or higher, write it down. Circle it. That simple subtraction often tells you more about your true risk than the top number alone ever will. Now take a breath. This is not a countdown to panic. It is one piece of data on one piece of paper. But it starts to tell a story your annual checkup usually skips. Let me introduce you to Grace. She is 68, a retired school teacher, and she worked hard with her doctor to control her blood pressure. After 2 medication adjustments over about a year, her top number sat at a beautiful 120. Everyone was thrilled. Except no one really talked about the fact that, as the dose went up, her diastolic had quietly drifted down to 52. At the same time, Grace started to notice her hands were often cold, even in a warm kitchen. Some afternoons she felt foggy. She was tired in a way sleep did not fix. She shrugged and said, "I guess I am just getting older." It is the most common and most misleading explanation we use. What was actually happening? Her medication, pushed to hit that perfect top number, had driven her diastolic so low that her heart muscle was not getting enough blood during its own resting phase. The very organ that pumps blood to the rest of her body was running on partial supply. Grace was coasting along on a target that only ever measured half the story. I am not telling you to stop your medication. That is dangerous. Full stop. The goal here is a smarter conversation with your doctor, one where you bring both numbers into the room, not just the one that gets circled. Start a simple habit. Whenever you get a reading, say both numbers out loud as a single phrase. 120 over 52. Not just 120 looks great. That one habit helps catch problems months before symptoms force the issue. And pay gentle attention to the small things. Cold hands, brief dizziness when you stand, afternoon fog that feels new. None of these prove anything by themselves, but they are worth writing down next to your numbers with dates. Patterns cannot show up if they are never written down. Now let's talk about Robert. He is 71, a retired contractor, sharp as they come, and extremely proud of handling his health on his own. For years, his systolic ran around 150. His diastolic hovered near 70. If you do the subtraction, that is a pulse pressure of 80. That gap alone should have raised a flag years earlier. It did not, because no one was doing the subtraction. Everyone was staring at 150, saying, "We'll keep an eye on it." Visit after visit, year after year. Then one Tuesday morning, while pouring coffee, his speech slurred for about 90 seconds. His wife noticed immediately. He brushed it off. "I'm just tired." By the time she convinced him to call anyone, the episode had passed. That event was a transient ischemic attack, a mini-stroke. A warning shot fired directly by that wide pulse pressure and those stiff arteries. And it almost went unanswered, because 90 seconds is just long enough for a proud person to talk themselves out of making a fuss. Here's your practice from Robert's story, and this one takes 2 weeks, not 2 minutes. A single reading, even a good one, is basically a snapshot of one random moment. What you actually need is the trend. 14 days of readings, same time each day, logged side by side. A stiff, high-risk artery does not reveal itself with a single number. It reveals itself as a pattern. Yes, that sounds like homework. It is not complicated homework. It is a notebook, a pen, and 2 numbers, twice a day for 14 days. That is the assignment. Now the third patient, Eleanor. She is 74 and one of those patients who comes in exactly on schedule every 6 months. Her numbers, on paper, always looked fine. Every visit, both systolic and diastolic, fell into what the chart called an acceptable range. Nothing flagged, nothing triggered an alert, nothing sparked much conversation beyond, "You look good, see you in 6 months." But if you quietly lined up her readings across 2 years, something else appeared. Her diastolic had been sliding down slowly from visit to visit. One time it was 68, next visit, 64, then 59, then 55. Each individual visit looked okay in isolation. Put 4 dots on a graph, though, and a clear downward line runs right through them. It was a trend toward lower and lower diastolic that nobody was watching, because nobody was looking at more than 1 dot at a time. This is exactly why home monitoring can matter more than occasional office checks. So let's get the technique right, because bad technique gives you bad numbers, and bad numbers give you false confidence or false fear. Use an upper arm cuff, not a wrist device. Wrist monitors are extremely sensitive to hand position and are notoriously unreliable, especially in older, stiffer arteries where every few points count. Sit still for 5 full minutes before you measure. Not while you're finishing a phone call, not right after climbing stairs. Just sit, feet flat on the floor, back supported. Do not talk during the reading. Talking alone can shift your numbers by several points. That might sound small, but for someone right near a risky threshold, a few points is the difference between catching a problem and missing it. Rest your arm on a table so the cuff is roughly at heart level. If your arm is hanging down at your side or propped too high, it can skew the reading, sometimes by more than you'd expect. And remember, one good reading proves nothing. 14 consistent readings tell you the truth. Let's add one more piece. Timing. Most people take their blood pressure medication first thing in the morning because that's when the pill box is on the counter. For some, that's perfect. For others, it means the medication's strongest effect hits in the afternoon, exactly when the body naturally dips, and that combination pushes diastolic lower than anyone intended. This concept, timing medication around your body's rhythm rather than the clock on the wall, is called chronotherapy. It is real. There is research behind it. But it is not something to experiment with on your own. Do not move your own dose to a different time of day because of a video. Instead, walk into your appointment with your 2-week log and ask, given when my numbers run lowest, does the timing of my dose make sense? That one question has changed more prescriptions in my practice than almost anything else a patient can bring up. Now here is an everyday factor that shifts your bottom number and costs nothing to fix. Hydration. Mild dehydration lowers your overall blood volume. Less volume means less pressure through stiff arteries. And for someone whose diastolic is already borderline, that small drop can push it into the risky zone, especially by late afternoon. This interacts with something called orthostatic hypotension, a sudden drop in blood pressure when you stand up quickly. Combine a low diastolic with even mild dehydration, and standing up fast can literally make the room spin for a moment. Most people shrug this off as, I got up too fast. Sometimes that's true. Sometimes it's your bottom number dropping further than it should. Here is a simple, no-risk habit. Drink a full glass of water within 30 minutes of waking, before coffee, before tea, before anything else. And when you stand up from sitting or lying down, pause for a few seconds with the hand on something stable. Give your body a chance to catch up. Now, the ranges we've talked about do not apply the same way to everyone, and this part matters. If you are 75 or older, your arteries have probably stiffened enough that standard textbook targets need to be personalized. What counts as too low at 50 can be a different number at 80. If you have diabetes, your blood vessels, including the tiny ones that feed your heart and brain, are already more vulnerable. That shrinks the safety margin on your diastolic. A reading that is tolerable for one person can be riskier for another simply because of the damage diabetes has already done. If you have kidney disease, your blood pressure regulation and your kidneys are locked in a loop. Change one, and the other reacts. That means standard cutoffs can mislead you, and adjustments need more careful monitoring. And if you are on 2 or more blood pressure medications, which is very common after 65, the combined effect on your diastolic can be larger than any single prescription would suggest. 2 individually reasonable medications can add up to a bottom number nobody ever intended.